Microphone test. Microphone test. Microphone test.
And whatever, yes. Yeah, a little bit of everything.
Okay, good, thank you. All right. Hello. I get one. Good morning, everyone, and welcome to this morning's Tom Lantos Human Rights Commission hearing on protecting health care during armed conflict. I want to thank our witnesses for taking the time to share their experience and their expertise with us today. And some colleagues may be coming in and coming out because there's a Foreign Affairs Committee markup at the same time, and then there's a caucus going on, and so it's a lot of things happening at once. But this is an important hearing. In recent years, we have seen report after report of attacks on medical personnel in regions where armed conflict is underway. Much of the reporting has come from Syria and Yemen. Just 2 weeks ago, the New York Times published a stunning account of the repeated bombing of hospitals in Syria by the Russian Air Force. In just one 12-hour period on May 5th and 6th of this year, 4 hospitals were bombed. These were not accidental bombings. We're not talking about collateral damage due to military attacks that were properly planned and executed. We're not talking about collateral damage due to military attacks that were properly planned and executed. These were purposeful attacks on installations that are supposed to be protected under international law. Even worse, these were attacks on medical facilities that had voluntarily provided their GPS coordinates to the United Nations deconfliction mechanism as a means of protection. The coordinates were in turn provided to Russia and other combatants, specifically so the facilities would not be targeted for attack. All 4 of the hospitals in the Times report were on the deconfliction list, yet they were attacked anyway. It is hard to overstate what a setback this kind of behavior is for the global consensus on the obligation to protect health care during conflict, a consensus that was constructed over the last 150 years has its origins in the experience of the American Civil War and was made law in the Geneva Conventions. The first Geneva Convention, adopted in August of 1864, was written to protect the wounded on the battlefield. That one of the countries undermining this hard-won consensus is a permanent member of the United Nations Security Council, a body charged with maintaining international peace and security, is especially frustrating and infuriating. At the same time, Russia is not the only bad actor here, and Syria is not the only situation of conflict where health care has come under attack. According to the World Health Organization, between January 1, 2018 and October 17, 2019, there were 1,604 attacks on health care, resulting in 328 deaths and 1,454 injuries in 10 countries or territories. The Safeguarding Health and Conflict Coalition, represented on our witness panel today, reports that in 2018, there were at least 973 attacks on health workers, health facilities, health transports, and patients in 23 countries in conflict around the world. The problem is widespread, which makes it worse. And the long-term consequences of these attacks also make the problem worse. Attacks on healthcare providers do not cause immediate injury and death. They can also have far-reaching and long-lasting destructive effects on entire health systems, leading to public health crises like the 2017 cholera epidemic in Yemen. The problem of attacks on healthcare during conflict is sufficiently bad that 3 years ago, the United Nations Security Council passed a resolution, United Nations Security Resolution 2286, that condemned attacks on healthcare and called on states to prevent them and to ensure accountability for those that occurred. The resolution was seen as a landmark. More than 80 UN member states co-sponsored it. It was unanimously adopted, and it had the full support of humanitarian organizations from around the world. But it hasn't been implemented, or at least not well enough. Only a year later, in 2017, the president of the ICRC warned that, and I quote, "We are at risk of creating a new normal. Too many actors are legitimizing attacks on health care as collateral damage rather than outrageous violations," end quote. So we are here today to ask what the United States can do, or what more can we do to push back against the continuing risk of a new normal that makes all of us less safe. We will hear from our witnesses both about positive steps the U.S. has taken and about areas for improvement. In the past, the United States has played a leadership role in ensuring global respect for the protection of health care. I want that role to continue, and I want it to be strengthened. And I very much look forward to hearing the recommendations to that end. Now, let me introduce our witnesses. Leonard Rubenstein is Director of the Program in Human Rights, Health, and Conflict at Johns Hopkins Bloomberg School of Public Health. The former Executive Director and President of Physicians for Human Rights, he founded and chairs the Safeguarding Health and Conflict Coalition, a group of 40 humanitarian, human rights, and health provider organizations that seeks to reduce attacks on and interference with health workers, patients, facilities, and transports. Alexandra Livan, did I say that? Good, okay. I'm from Massachusetts, I don't always pronounce things properly. Is the head of a regional delegation, U.S. and Canada, for the International Committee for the Red Cross. Her position entails managing the ICRC's relationship with the U.S. and Canadian governments, including the ICRC's regular visits to the detention facility at Guantanamo Bay, Cuba. She previously served as the Chief of Staff to ICRC President Peter Maurer in Geneva. Randall Bagwell serves as the Senior Director for International Services, U.S. Programs, and is responsible for international humanitarian law, restoring family links, and the Missing Maps program for the American Red Cross. Before joining the Red Cross, Mr. Bagwell served for more than 35 years in the U.S. Army as a legal officer specialized in IHL, infantry officer, and infantry soldier. He deployed twice to Afghanistan and once to Iraq before retiring from the Army in 2018. Susanna Sirkin is the Director of Policy and a Senior Advisor at Physicians for Human Rights, where she oversees PHR's engagement with the United Nations and has organized and participated in many health and human rights investigations, including the documentation of attacks on healthcare facilities and personnel in conflict zones in Syria and Yemen. She represents PHR as a member of the Steering Committee for the Safeguarding Health and Conflict Coalition. Dr. Larry Lewis is a research director at CNA, a nonprofit research and analysis organization located in Arlington, Virginia. He spearheaded the first data-based approach into protecting civilians in conflict, analyzing military operational data in conjunction with open source data. He has worked to help militaries reduce civilian casualties in their operations through studies and by developing tailored policy and practical measures complementary to existing protections and principles of international humanitarian law. As I said at the beginning, I think this is a very important topic, and I appreciate all of you being here. And Mr. Rubenstein, we'll begin with you.
Thank you, Chairman McGovern, for inviting me to participate in this important hearing on protection of health care in conflicts and emergency. I chair the Safeguarding Health and Conflict Coalition, a group of 40 organizations and academic centers that promote the security of health workers and services threatened by war or civil unrest. The coalition issues an annual global report on violence against health care, presses governments and the UN to take steps to advance protection of health care, and support civil society groups throughout the world. I'm a faculty member of the Johns Hopkins Bloomberg School of Public Health, but I am not speaking for the Bloomberg School or the Johns Hopkins University, and my views may not reflect those of all members of the coalition. As Chairman McGovern said, concern to protect the wounded and sick in war was the focus of the first Geneva Convention back in 1864. And since then, its protections have strengthened considerably. The bedrock principles are easily stated. Hospitals and health workers may not be attacked. Parties to conflicts must provide care to the wounded and sick and do so impartially. Health workers must not be punished for offering health care to someone in need, no matter what the affiliation of acts of the patient. Parties to conflicts must distinguish between civilians and military objects and take special precautions to avoid harm to health facilities. These principles have been reaffirmed frequently, most recently in the Security Council's Resolution 2286 in 2016. Yet violence against health care in conflict remains relentless. Our coalition report for calendar year 2018 found almost 1,000 reported attacks in 23 countries in conflicts around the globe. Hospitals were bombed or shelled in 15 countries, most notably in Syria, where more than 100 hospitals and clinics were damaged and 21 were destroyed. In Yemen, there were at least 7 aerial attacks on health facilities that year, as well as 15 cases of surface shelling of health facilities and transports. In Afghanistan, the Central African Republic, the Democratic Republic of Congo, Pakistan, Somalia, and Sudan, community health workers vaccinating children against disease were attacked. As we speak today, the assaults continue. In the joint Russian-Syrian campaign in Idlib, 51 hospitals have been bombed since the end of April. As of last week, 181 health facilities in Afghanistan were forced to close this year, and only 27 have reopened. The effects of this violence are incalculable, not just for the immediate victims, for those needing care a day, a month, or a year later. Health systems in Libya, South Sudan, Syria, Yemen, and elsewhere have been reduced to a patchwork of clinics and hospitals that cannot begin to meet human needs. Violence against health workers and clinics has severely impeded the Ebola response in the Democratic Republic of Congo. Health workers are at risk from counterterrorism laws too. Principles of humanity and impartiality embraced by the Geneva Conventions forbid punishing health workers for doing their ethical duty of care. But now laws throughout the world deem certain people unworthy of health care and criminalize health workers for providing it. On a personal level, I've been awed by health workers who explain to me that their commitment to their patients leads them to keep working, even when they're under assault. But it is wrong to ask them to put their lives at risk for serving patients. They need support, and most of all, protection. The United States has often been a leader in seeking to end these violations. Yet across multiple administrations, the U.S. at times has remained passive or actively opposed reforms needed to protect health care. I want to address 5 gaps in U.S. policy and practice and what Congress can do about them. First, interpretations of U.S. counterterrorism law to criminalize health care to alleged terrorists must end. These laws also deny asylum to health workers fleeing persecution. 20 years ago, Chechen and Russian forces threatened the life of a Chechen surgeon for treating the wounded on both sides. He escaped to the United States and was granted asylum. Today, though, he might well have been denied refuge because some of his patients were designated as terrorists. There's emerging bipartisan consensus that these laws do not make us safer and add unnecessarily to human suffering and deprivation. Congress should preclude criminal prosecution for providing health care to anyone in need. And at the Security Council, the United States must stop opposing resolutions that seek to ensure that counterterrorism laws globally do not jeopardize medical and humanitarian response. Second, the U.S. has provided military support and arms sales to entities that attack hospitals in war, particularly to the Saudi-led coalition in the war in Yemen. Congress deserves credit for seeking to end these transfers, and we know these efforts are continuing. More could be done, though, to strengthen prohibitions in U.S. law on military assistance that enables or facilitates attacks on health care. Third, the Pentagon has not addressed Resolution 2286's call to improve military doctrine and training to avoid harms to health care. There is evidence that routine operations at checkpoints that delay patients from reaching care and violent hospital searches that deter people from seeking it may actually harm more people than those hurt in spectacular attacks. The ICRC has provided guidance to address these concerns at the operational level, but the Department of Defense has not acted. Congress should require it to do so. Fourth, the Department of Defense needs to commit more explicitly to the protection of civilian health workers and facilities, who are by far the majority of health providers in conflicts. In the wake of the Kunduz bombing in Afghanistan, then Secretary of Defense Ash Carter issued a memorandum to all components reciting principles of protection of medical care, but it only applies to humanitarian providers. The omission undermines protection of civilian workers and health facilities, and Congress should demand their inclusion. Finally, Congress can advance accountability. It can require the State Department to include incidents of violence against healthcare in its annual human rights country reports. It can share information with investigators of war crimes against health facilities and strengthen the State Department's Office of Global Criminal Justice. We understand, Congressman McGovern, that you're considering legislation to address this problem, and the coalition would be very pleased to work with you and offer technical assistance to see these reforms go forward. Thank you.
Thank you very much, Mr. Poivon.
Thank you, Chairman McGovern, for holding this hearing on the protection of healthcare in armed conflict. It's an honor to be here. The ICRC is a global humanitarian organization composed of 18,000 staff working in more than 90 countries. We operate in a neutral, independent, impartial manner for the sole benefit of people who are caught up in war, the most vulnerable people. As guardians of the Geneva Conventions, we advocate for the protection of those who do not take part in the fighting. At the same time, we remain staunchly pragmatic in our ways, recognizing that death and destruction is an inevitable part of war. We seek to minimize suffering by engaging armed actors directly on their behavior on the battlefield and by remaining close to the people we serve. Proximity and dialogue requires access, it requires acceptance, and it requires security for our staff, all of which is a daily challenge for a frontline organization. The U.S. government, including Congress, has been a steady supporter of our work, and I'd just like to seize this opportunity to express our appreciation for the support. When it comes to the protection of hospitals, medical personnel, and ambulances, the ICRC has taken an unusually assertive and visible stance. The problem is rampant, as you rightfully said in your introductory remarks. It's multifaceted, and it is in many ways personal. Attacks against health services are the antithesis of humanitarian action. The community of actors that this panel represents this morning has been working hard to raise awareness about the issues, to build political will to address the problems, and to help turn this political will into concrete action so that our world can be one in which my enemy's doctor is not my enemy. In what follows, I'd like to share some thoughts on the problem as we see it and offer some recommendations on what more can be done. First, important to describe this problem as global in nature. First responders around the world experience violence. It's not just an armed conflict problem. It's more acute in armed conflict, but it takes place wherever there's crises. While the focus of today's hearing is on what happens in war, and rightfully so, we feel that it is important to broaden out the lens so that policymakers and the public at large are able to connect with what is happening in countries that are geographically far away, and to see the parallels with some of the painful experiences and unacceptable situations that are taking place in their communities and in hospital wards closer to home. Second, the causes of this problem, as you also mentioned, are very wide-ranging. Attacks on healthcare may be part of a deliberate strategy to target civilians, but it could also be the result of negligence or ignorance. It may happen because there's no more trust in the enemy's use of medical premises and staff. Indeed, parties to conflict continue to misuse medical facilities and vehicles by employing them for military purposes. In some places, healthcare workers themselves are being co-opted by political and military strategies, or are simply following their own deeply held views when they deny care for unlawful reasons to wounded and sick persons. Addressing each one of these scenarios requires a tailored approach, rooted in a solid understanding of the context. Third, this problem manifests in multiple ways, and its effects are far-reaching. In many countries, large areas of land or portions of cities are off limits for healthcare workers, for patients, for medical supplies. Blockades, sanctions, and invisible borders prevent the movement of health personnel and of patients. All of this results in the suspension of preventive and curative health programs and has disastrous consequences for the population for whom these programs are intended. And it also often reverses decades of development work or impedes the containment of epidemics. Finally, Mr. Chairman, it is not new, but it's not getting better. Protecting the medical mission in times of war has always been a challenge. There's never been a golden age of respect for the rules of war. What is new is the increasing number of actors on the battlefield, many of whom do not feel bound by the rules. What is new is the notion that certain groups are not worthy of protection because of their extremist views and actions. What is new is the extent of the problem and what is at stake if we do not manage to curb the violence epidemic that plagues health services in armed conflict today. You will see from my written statement that the ICRC concurs with many of the recommendations that were put forward by LEND. So let me, in the interest of time, perhaps just focus on two. The first, at the risk of stating the obvious, it is important for us to repeat that the U.S. government must use every opportunity to reaffirm its commitment to respect and ensuring respect for international humanitarian law. The rules established 70 years ago in the Geneva Conventions to protect healthcare in armed conflict are extremely robust. There's little ambiguity around them. Earlier this year, in May, the Senate Committee on Foreign Relations adopted a resolution reaffirming the importance and relevance of IHL. Initiatives like these are critical to keep the commitments effective and alive. Secondly, it's important to ensure that the protection of healthcare figures prominently in the civilian casualty policies of the U.S. Armed Forces. As you may know, the Department of Defense is currently working on a civilian casualty mitigation instruction. This is a great opportunity to reaffirm and highlight the protection of healthcare as central to minimizing civilian harm, be it in the context of operations carried out by the U.S. military or by U.S. military partners. We need to keep working together to narrow the gap between the rules on the books and the behavior we observe in the battlefield. We need to push back on the new normal that you mentioned earlier, that accepts attacks against healthcare as just another reality of war. Hearings such as these is a step in the right direction, so thank you.
Thank you very much. Mr. Bagwell?
Good morning, and thank you, Chairman McGovern and the Tom Lantos Human Rights Commission for the privilege of testifying before you today on behalf of the American Red Cross. We applaud the Commission for holding this hearing and for your interest in the topic of protection of healthcare workers and facilities in armed conflicts. It is the mission of the International Humanitarian Law, or IHL team, at the American Red Cross to inform the American public on IHL so that they are informed of the rules of war and equipped with an analytical framework with which to evaluate events in armed conflicts around the world. Forums such as this one allow us to do that. I want to begin my comments today by commending the United States government for its work and leadership in IHL, and more specifically in the area of protection of healthcare workers and facilities in armed conflict. While no country is perfect in this area, the U.S. is recognized world leader in IHL, setting an example that is emulated around the world. During the U.S. Civil War in May 1862, just a few hours west of here in Winchester, Virginia, 7 Union military doctors were captured by Confederate forces. Recognizing that it helped no one to hold doctors as prisoners of war, the senior Confederate medical officer negotiated an agreement with the Union doctors to not only release them, but also agreeing to work towards the release of all medical officers from both the North and the South. In April the next year, General Order Number 100 was issued by President Lincoln to Union forces. The Lieber Code, as this order became to be known, contained 2 articles that specifically related to the treatment of medical personnel and wounded soldiers. These articles form the basis of the rules still found in IHL today, that medical workers are not combatants and that they should treat all those in need with impartiality. Over time, these concepts have grown into the broader protections for medical assets and extend well beyond protecting just military medical personnel. IHL now protects both military and civilian health assets. In today's conflict, most of the casualties are civilians. Even if civilians are not deliberately targeted, they are unintentionally injured in attacks. When they are wounded, they often have less access to medical treatment than soldiers. Movements by civilians in conflict zones, already dangerous, can be even more deadly as they move through checkpoints to seek medical care. I am a 30-year veteran of the U.S. Army, having served early in my career in the infantry and the latter part as a judge advocate. During my time in uniform, I deployed to combat zones 4 times. I am proud of the U.S. military's efforts in protecting medical assets. However, I know that there is more that can be done. Measures that will not only improve how the U.S. military operates, but will serve as a catalyst of change for militaries around the world. First, our military should develop specific doctrine and training on how to expedite medical evacuations through checkpoints. In military operations, denying the enemy freedom of movement is critical. Though critical, the measures to do so can frustrate those that need medical care. At best, checkpoints impede traffic and delay care. At worst, vehicles rushing someone to medical care may be mistaken as a threat and fired upon by soldiers. Complicating the issue is that in many countries, medical transportation does not look like it does in the U.S. In many parts of the world, people are routinely transported to hospitals in private vehicles. I personally witnessed how coordination with local officials and aid workers, followed by training of security forces, can make a difference. For example, in southern Afghanistan, the International Committee of the Red Cross established a medical evacuation system for the sick and wounded. When a person needed emergency medical transportation, someone would call the ICRC and they would dispatch a local taxi driver to pick up the person and bring them to the hospital in Kandahar. In Afghanistan, a taxi isn't a car with a sign on top. It's someone who drives his personal car. With the taxi being just a man in a car with a wounded person in the back seat, it was common for these drivers to be detained for interrogation at checkpoints, resulting in delayed medical treatment and sometimes death. After coordinating the system with the U.S. and local forces, an agreement was reached where the ICRC provided identification cards to these drivers. The soldiers were then trained that once a driver was identified as a medical driver, they should allow his vehicle to pass without a lengthy interrogation. While this is a success story, it's an ad hoc solution in one country. We need to build on this success by writing into Department of Defense doctrine the ability to apply other similarly flexible solutions to ensure people can reach medical care. Second, the U.S. military leadership needs to raise awareness within our armed forces of respect for local medical personnel and facilities. Civilian medical personnel and facilities may not display the protective emblems of the Red Cross, Red Crescent, or Red Crystal. Failure to display these emblems does not deny them a medical protection. Under IHL, it is still incumbent upon all fighters to respect and protect all medical personnel and facilities, and not just protect them from deliberate attack, but also to protect the freedom to do their work. This means the ability to freely travel and to conduct medical operations within the area of operations and to bring in medical supplies. Finally, as a nation, we must be cautious that we do not allow domestic laws to have the unintended effects of criminalizing humanitarian aid work. Laws that broadly criminalize aid to the enemy may have a definition of aid so broad as to potentially criminalize providing medical aid to sick and wounded enemy fighters, or to criminalize the training of people to administer medical aid to them. In this regard, it was encouraging to see in March of this year the United Nations Security Council included in its unanimous resolution on countering the financing of terrorism language requiring states to consider the potential effects these new laws may have on exclusive humanitarian activities, including medical activities that were carried out in a manner consistent with IHL. We encourage any new U.S. legislation to also be reviewed to ensure that it does not inadvertently criminalize humanitarian aid. The overarching principle of international humanitarian law is to spare civilians as much as possible the suffering of war. Protecting and respecting healthcare workers and facilities goes directly to the heart of this principle. Doing so means that we meet our treaty obligations under the Geneva Conventions, but perhaps more importantly, it reflects who we are as Americans. Thank you.
Thank you very much. Ms. Sirkin?
Thank you, Co-Chair McGovern, and also to Co-Chair Smith for holding this hearing at a most critical time, and for inviting me to testify before the Lantos Human Rights Commission on behalf of Physicians for Human Rights. We are an international, non-governmental organization that brings science and medicine to the defense of human rights. For more than 30 years, we have investigated and reported on violations of the laws protecting health facilities and personnel during armed conflict. As my colleagues have noted, such attacks are not a new phenomenon, but it is inexcusable that these humanitarian norms continue to be so blatantly flouted. In many of today's conflicts, hospitals are now places of fear and danger instead of hope and recovery. In fact, the scale and scope of attacks on healthcare facilities and health workers today in conflicts represent unprecedented deterioration of international humanitarian standards. We see this in Yemen, where indiscriminate warfare and callous disregard for distinction and proportionality have caused widespread destruction of access to food, water, and medicine. And respect for humanitarian law has also been shredded in Syria, where a deliberate campaign of military strikes targeting health workers and health infrastructure has obliterated what was once a highly developed health system. I will focus on these two most egregious current examples of healthcare under siege. The Syrian government and its allies, including Russia, have targeted health facilities as a strategy of war to punish civilians in opposition-held territories and force them into flight. PHR has rigorously researched attacks on Syria's healthcare system by all parties to the conflict. From March 2011 through August 2019, PHR has corroborated 583 attacks on at least 350 separate health facilities in Syria, as well as the killing of at least 912 medical personnel. More than 90% of these attacks are attributed to either Syrian forces specifically or to Syrian and Russian forces together. We'll soon be publishing research pointing to the Syrian government's effective criminalization of the delivery of health care through its detention, torturing, and killing of health workers. Since the Syrian government's escalation in Idlib began in late April of this year, PHR has received reports of more than 57 attacks on health facilities. Among the many we have confirmed, 3 were carried out on a single day, May 5th, as you mentioned, Congressman McGovern. A UN-coordinated agreement that you also mentioned had notified all Russian, Turkish, and international coalition forces of the locations of these health facilities, and it was intended, as noted, as a strategy to protect them. But this so-called deconfliction mechanism has been violated again and again. The Syrian and Russian governments have known exactly where most health facilities are located, and yet they have continued to target them, leaving courageous doctors to provide life-saving care under fire. And as you noted in your introductory remarks, Congressman, the New York Times recently republished this damning expose on Russian culpability for these heinous war crimes, using a trove of Russian Air Force radio recordings and flight spotter logs. The magnitude, frequency, and distribution of attacks on healthcare in Syria over the past 8 years reveal a widespread and systematic pattern of violations, crimes against humanity. The United States must exert influence wherever it can to stop these crimes and work with other nations and entities to ensure that any resolution to the conflict in Syria carries justice and accountability as a core component, which is so essential for a sustainable peace. Although the UN Secretary General has indeed launched an internal investigation, it's quite limited, into the recent attacks on UN-supported healthcare facilities, this narrow inquiry should not distract from the overall imperative to hold perpetrators of 8 years of atrocities to account. The UN Security Council failed to refer the case of Syria to the International Criminal Court due to China's and Russia's vetoes. So now, national courts must step up efforts to prosecute these crimes, and they are starting to do so in European courts. And UN member states, including the US, must reinvest in the international impartial and independent mechanism known as the IIIM for Syria. The US government could support the IIIM by sharing non-public information with prosecutors under the ironclad guarantee that such information could not be disclosed without US government consent, as it did when it negotiated with prior international courts for Yugoslavia, Rwanda, and Sierra Leone. Let me now turn to Yemen, which has also endured years of devastating attacks on healthcare facilities and personnel. Since the escalation in 2015, parties to the conflict have damaged and destroyed hospitals through air and land-based attacks and have actively prevented health workers from carrying out their duties. By repeatedly attacking medical facilities and workers, the Saudi Emirati-led coalition, their Houthi opponents, and the internationally recognized Yemeni government have demonstrated their inability or unwillingness to comply with the most basic international rules and norms that protect civilians and civilian infrastructure from attack. These violations have effectively denied Yemenis access to medical services when they need them most. The U.S. continues to have the most influence over the Saudi Emirati-led coalition. So we welcome bipartisan efforts to end U.S. involvement in the conflict and to restrict U.S. arms support for the coalition in Yemen. Specific, targeted, time-bound holds on U.S. munitions are a key form of leverage that the United States has to curtail attacks on health care, to press for accountability, and to urge support for a UN-led solution to this horrific conflict. We urge Congress to support amendments currently under consideration for the FY20 National Defense Authorization Act, the NDAA, that can leverage U.S. arms transfers to Saudi Arabia to limit capacity for the destructive strikes against civilians and health facilities in Yemen. We support the amendment by Representative Tom Malinowski that includes a one-year ban on Category 4 air-to-ground bombs and missiles. Across all conflicts, we urge the U.S. government to formalize more structured and rigorous guidelines and procedures for accountability measures in cases of attacks on civilians or other violations of international humanitarian law. This should include enhanced scrutiny by the Departments of Defense and State of end-use monitoring of American-made munitions and other military supplies, as well as addressing humanitarian violations by coalitions that the U.S. supports. We recommend that the Department of State formally include incidents of attacks on healthcare in its annual human rights country reports to underscore attacks on health workers and facilities as a critical human rights issue. Thank you very much for this opportunity and for your commitment to protecting healthcare in conflict.
Thank you very much. Dr. Lewis?
Co-Chair McGovern? Yes, thank you. Co-Chair McGovern, thank you very much for this, for the attention on this critical issue. This morning we've heard about tragedy. Heard about tragedy when the results when militaries attack medical facilities and when medical services are disrupted. But there is some good news. Better protecting medical care in conflict is a problem we can solve. For example, stopping attacks on medical facilities can be addressed by addressing the common failures that lead to these tragedies. So I'm with CNA, which is a nonprofit research organization that focuses on national and homeland security challenges. And I've spent 10 years studying civilian casualties, why they happen, what the common drivers are, and then working with militaries to help address them. So I've gone to Iraq, Afghanistan, other places like that about 15 times, working with militaries as well as the Saudi-led coalition in Yemen. So the basic idea behind this work is this. If we better understand the root causes of why these tragedies happen, then we can come up with more effective ways to avoid them. So with that goal, I've examined over 1,000 real-world cases of civilians being harmed in combat operations. And then identifying patterns of harm so that we can fix it. And this database approach works. I worked with General McChrystal in Afghanistan, and we analyzed incidents, identified common patterns of harm, and then worked with U.S. and international forces on preventative measures that addressed those patterns, and the numbers went down. So we can take this same approach with the protection of healthcare. I do want to be clear that for the goal of avoiding attacks on medical facilities, some important advances have already been made. And so the U.S. military, over the last few decades, they've done important work on estimating civilian casualties and also on the no-strike methodology that helps protect against attacks on protected entities. These are important developments. I'll also say, though, that those methodologies have been used in these recent conflicts with those processes in place, which suggests that more work can be done to make it better. So, for attacks on medical care, and I'm going to leave out the case of Syria and Russia. That's a different problem that we need political solutions for. But for these inadvertent attacks that we see, both from the U.S. but also in Saudi and around the world, why do they happen? That's an important question. So in our research, we've seen three causes. Military forces they fail to use known information about the location of hospitals to deconflict their attacks. They fail to identify attacks as such, fail to identify hospitals as such during attacks, and then they don't follow historical best practices for protecting civilians. I'm just going to focus, for the interest of time, on one of those contributing factors, the failure of militaries to identify hospitals. To be fair, it can be difficult to identify hospitals in a combat zone. They're not always in easily distinguished structures, such as established hospitals. And while IHL is crystal clear about the protected status of medical facilities, the only practical identification measure IHL gives is in the original Geneva Conventions of 1949 that medical facilities may display a red cross or a red crescent to show they are protected. And unfortunately, looking at modern militaries and how they conduct war, advanced technological developments in sensors and networking can make this feature less effective. For example, a colored marking won't necessarily be seen by a pilot who is observing infrared sensors in an airstrike. And that's a capability used by many modern militaries. So what can we do? And the list is long. I'm just going to give a few possibilities. So reflecting that militaries are increasingly using data links and systems for better situational awareness, militaries can require that such systems display and exchange information on protected entities such as hospitals. So you could have this available in a cockpit or exchanged over secure data links. Many militaries already do this for the protection of friendly forces and for the exchange of threat information, but there's often no requirement to do this for protected entities. Another idea. Many are currently worried about military applications of artificial intelligence. That's a common fear. But I've written about ways to use AI for good in war, and this is such an opportunity. So I've been recently talking to a group in Australia who is interested in leveraging artificial intelligence to better protect medical facilities. For example, using AI to improve the identification of hospitals using machine learning techniques. So these examples are illustrative, just to show that there's a lot of room for creativity if we have the will to do something more. So I also want to say, these are new capabilities, and fielding new capabilities takes time. So are there triage type measures that can also decrease risk in the meantime? And there are. So the problem I mentioned with infrared sensors not seeing colored symbols on the battlefield, that was also seen in Iraq, and it resulted in friendly force fratricide. So what the U.S. forces did is they had an easy, cheap, and fast solution. They put out these panels that had both orange color and infrared signatures that could be seen by a variety of different sensors on the battlefield. So you could say, as militaries take time to develop more nuanced capabilities, they could, in the short term, possibly distribute such measures to humanitarian groups, not as a requirement to avoid attacks, but as a part of a larger safety net to aid protection efforts. And we have a paper with the discussions of more of the challenges and solutions. But I just want to share those examples to illustrate that this is a tragic problem, that it's a solvable problem. Much more can be done through practical measures that countries and militaries can take. And that includes new capabilities, but it also includes strengthened doctrine, training, and policy. All that's required is that countries like the US make practical steps a priority. And as has already been noted, the US is a demonstrated global leader in the commitment to international law and also in concrete steps to better protecting civilians in conflict. So this is another opportunity for the US to show leadership by promoting practical steps to better protect medical care where such protection is needed most in the heart of conflict.
Well, thank you very much. Thank you all for your testimony. It seems that we're living in a time where every day you pick up the newspaper or turn the news on, and you just see more and more violence and more brutality and the ravages of war. And there's something particularly despicable about targeting healthcare, in these conflicts, and some of it may be by accident, but I think too many cases it's intentional. It's interesting you said about artificial intelligence. I'm really nervous about that whole link between artificial intelligence and anything to do with war, because I've been to too many briefings where people have talked about, I'm naming it this, but they don't name it this, killer robots, if you will, where they remove the man in the loop, and I just don't want to desensitize us from how horrible war is either. But I mean, it'd be interesting at some point to get your opinions on how it could be used in a different way. Let me just begin with this. I mean, has the U.S. government done enough to implement U.S. Security Council Resolution 2286? I mean, or should we be doing more? I mean, you said that we're an international leader, in terms of upholding a high standard of human rights around the world. I said I was worried that we're losing ground on that, but I'd be curious, just a quick answer from everybody here. I mean, can we do more, and what should we be doing?
We can do a lot more. There's been very little action on 2286 at the Pentagon and in other agencies. All the calls for reforming laws, for reforming military practice, for improving accountability, that has not happened. In the wake of the Kunduz attack in Afghanistan, the Pentagon conducted a credible investigation, I think, but I think that was an exception. So there's a lot that should and could be done.
Mr. Bagwell?
Yes, sir. I don't think we're losing ground as a leader. I think we are a leader. We're either a leader that we do something, or we're a leader in doing nothing. But the other countries are watching our example. I absolutely think there is more that can be done. We need to incorporate the procedures to protect medical care into doctrine, and then incorporate that into our training. And until we do that, and until we require that to be done, we will continue to not do it.
And what is your answer? I mean, are there other countries that are playing a leadership role, and are there countries where we should emulate what they're doing?
At the UN, there's a group of friends of Resolution 2286, and a number of governments, and some of the ones that you might expect, Sweden, Switzerland, others, but also Germany, France, and the UK in various ways have been supportive. I think the US has been in that mix some of the time, but this issue that Len Rubenstein and others have mentioned about the potential criminalization of the delivery of health care, under counterterrorism measures is something where the U.S. is clearly deficient right now, and it's quite glaring. So we're not a leader on that issue of really, and to continue to criminalize healthcare or deny asylum, for example, to people who have treated the sick and the wounded without discrimination, which is what international humanitarian law requires and also what medical ethics requires, is in a way undermining of IHL, and including Resolution 2286, which reinforces that. I think the other issue that we've seen in the Coalition for Safeguarding Health in Conflict is that 2286 was a big day. There was a lot of publicity around it, but when it comes around every year and there's supposed to be reporting, I think the U.S. could play a stronger role in pushing for that. That would include inclusion in the country reports, that political officers, human rights officers at U.S. Embassies could start to gather that information, could share with the UN, with the WHO. And then finally, I do think this accountability issue is lacking for the U.S. And it's very glaring in Yemen. We're supporting, in a big way, a government that is literally bombing hospitals now for years and just completely destroying health, and it's glaring. We could change.
Ms. Morgan?
Yeah, I think what I would add is that the attention that we're seeing here on mitigating civilian harm, somehow there's a missed opportunity to spotlight the particular issue around healthcare. So I would say what more could be done would be to acknowledge that in what's happening now. I think that the Department of Defense has been extremely forthcoming in asking us and others to contribute. And I think there's just a sense that more effort, more granularity around this issue would be quite helpful. Specifically, if I look to the consultations that we led with other countries, with the military of other countries, we noted that procedures around searches and arrests that take place in health facilities, or behavior at checkpoints, or operations that take place close to health facilities, these are all spaces where many countries acknowledge that the guidance is insufficient. So again, to contribute to the commitments that are made under 2286, the very concrete things that can be done is now to use this evidence that we have and to incorporate that in the efforts that are made on civilian casualty mitigation writ large.
Dr. Lewis?
Yes. So definitely more can be done. And just to add on to your comments, I'm reminded of a similar situation in the early days in Afghanistan. So in the 2005-06 timeframe, President Karzai went to the U.S. and international forces and said, "You're killing too many of our people. Can you please stop?" And so General Barno and then like 4 different generals just started doing things to try to address this issue. And every year he would come back and say, "You're still killing too many of my people." Finally, 2009 was when I was sent over to try to help to reduce civilian casualties. And the issue was that the military was trying, but they had a certain way of doing things, and they weren't thinking creatively, thinking out of the box, right? And they weren't thinking about, they didn't go back and analyze why it was happening. So they weren't having creative solutions. And then finally, when we started changing things and adding some of these additional measures, the numbers went down. I feel like we are in this early stage with medical facilities. We're not thinking through what is actually going to be constructive.
So the issue, I mean, we have the UN resolution, right? Everybody says that, it's a bad thing to target health care, and yet it still happens. So, what are the accountability mechanisms that we could maybe put in place that, so that there's a more serious consequence when nations do this?
Well, as I mentioned in my testimony, I think support for whatever international mechanisms exist, especially for the most egregious ones, when the Syria example is so blatant. I think it's definitely a challenge because the Security Council is completely paralyzed when it comes to Russia, China vetoing the proper accountability measures, which indeed should be the International Criminal Court. And of course, the U.S. is currently not a big fan of that court either. But nonetheless, there was support for this IIIM, the Independent Investigative Mechanism, and the U.S. has supported it and should continue to support it, and it is starting to make a difference in terms of prosecutions. We have, to my knowledge, never seen an actual international case of criminal accountability for attacks on health care delivery. And starting to set a precedent and turning the tide of impunity would be big, because it would start to send a message that, no, you can't just get away with deliberately bombing hospitals and killing doctors year after year after year. So there are ways to start working on accountability. I think there are other accountability measures, including sanctions, certainly restrictions on military aid, but also public condemnation, which I think we would like to see more of in the immediate aftermath of attacks. I think the fact that the Kunduz incident, where the Doctors Without Borders hospital was attacked, got so much visibility. It was a very important wake-up call and honestly an education for many other actors who watched what happened there, watched the debacle and the horror of those people dying, and the way in which, as Len mentioned, the Pentagon did indeed do a very extensive investigation and then made it public. But there could be a lot more like that, even with, perhaps hopefully much more minor incidents, where there could be a example setting of how do you investigate, how do you hold people accountable.
Mr. Rubenstein?
If I could just add one aspect. Suzanne has mostly talked about accountability at the international level and all the diplomatic, legal, economic, foreign policy tools that can be used. But there also has to be greater accountability within the military. We know, for example, that no matter how soldiers behave at checkpoints, they're never held accountable for not allowing an ambulance to get through in cases where someone dies or a woman gives birth at the checkpoint. It's accountability at every level, down to the lowest level. There has to be a message sent. It may not be a criminal prosecution, but there has to be a commitment to holding frontline soldiers and commanders to account in a systematic way throughout operations, and we're not close to being there yet.
Dr. Lewis?
Yes, so two things. One on the accountability and basically highlighting concerns about, for example, Russia. I think, I was in the State Department for a few years. We're not very good at consistent messaging. So there are so many different opportunities where this is something we can talk about in terms of concerns. And I think of like the UN CCW framework, which is an IHL specific forum. And other countries will go and actually criticize when there are clear violations of international law. We tend not to do that. So it seems like that could be another opportunity for us to highlight the grave concerns that the U.S. has, just being more consistent and pervasive in the messaging we send. The other piece is that we can also highlight the egregious nature of those acts by more deliberately being careful ourselves. And so, Kunduz, yes, we did acknowledge it. We did learn. I think we didn't learn as well as we should have, but there was at least transparency there. But we also, we have significant security assistance, right? And Yemen is a great example of those are countries that are operating with our weapons, our aircraft, and training, and that's not going so well. And so, when we talk about practical measures that the U.S. can do better, those are also things that we can try to push within the security assistance piece, try to lower the number of attacks that are happening in the spheres that we can control more directly, and that highlights even more the concerns about these other actors that are doing it deliberately.
Yeah, and I think that there's a case being made that we need to be consistent, so that when our ally does something, that we call it out in the same way we would call out, a bombing of a hospital by someone who's our adversary. Mr. Bagwell, you also serve as a judge advocate. Could you comment on how the United States ensures accountability for persons who target or fail to protect medical facilities?
Thank you for that. The U.S. military for years has held soldiers accountable for clear violations. They often don't do so or haven't done so in international forums. They've done so in domestic forums, at court-martials, through administrative actions, and they continue to do so. When you think about as Leonard had mentioned about holding soldiers accountable, the first step in accountability in the military is to ensure the proper training. Before we can ensure proper training, we have to ensure there's proper doctrine to train on. And currently, right now, for instance, at a checkpoint, I'm concerned that the military doesn't have proper doctrine to expedite medical care through a checkpoint. So it's difficult for our soldiers to do that. When we have seen clear violations, there have been numerous court-martials that have shown up over the last 16, 17 years for examples of ignoring rules of engagement and other procedures. So the military does have, I think the U.S. military has a good mechanism for internal accountability. They tend to investigate themselves well, as I think Kondus showed. But I certainly think there's more that we can do both in education, in training, as well as with accountability.
Ms. Boivin, you mentioned that the DoD is currently working on a protection of civilians policy, and that you are encouraging the department to have a focus on protection of health care in that policy, and I'm glad to hear that. That's good. Can you share a bit about what types of policy guidance military should develop to protect and safeguard access to health care in conflict?
Yes, thank you for that question. I think a number of actors have been invited to contribute, and so we've decided to focus on a couple of things. I think methodologically, to build on what Mr. Lewis was mentioning, seeking to take advantage of the, if I may use that language, of the vast amounts of resources that are put into security cooperation. So trying to encourage the U.S. to incentivize better behavior of their partners through these agreements. So for us to better understand them, but also to ensure that we look at the complex web of security cooperation agreements that exist and find ways to ensure that international humanitarian law rules make their way into that. You were talking about accountability earlier on. This is a mechanism for accountability. Specifically on healthcare, as I mentioned previously, we think that there can be more done on guidance related to search and arrest in health facilities, more done on identification at checkpoints, and the specifics of the way in which operations are conducted near health facilities. These are issues that are today covered in some respect, but that could be covered in with more specifics moving forward. So that's going to be the nature of the conversation that we're going to seek to have with the DoD.
Ms. Shirk, in your testimony, you recommend that Congress and the U.S. government work to formalize more structured and rigorous guidelines and procedures for accountability measures in cases of attacks on civilians and civilian infrastructure or other violations of international law, in particular attacks on healthcare facilities and health workers in conflict. Can you elaborate a little bit on the guidelines and procedures that you have in mind?
Follows from what our colleague at the ICRC has just stated. There isn't a lot out there on detailing exactly what can and should happen when these violations occur, both when the U.S. Military itself may commit violations, as well as, in particular, allies who we're supporting. And there really, as far as I know, it's new work to be done that would be much clearer both within the State Department and DoD to understand the actual protections in more detail, because there are some complicated situations, and the area around, for example, this criminalization of healthcare delivery, which gives license, if you will, to violations perhaps as an excuse that it's okay to bomb this hospital. There's no accountability here because there was perhaps a military operation going on next door, or there were snipers, 100 feet from the health facility, et cetera. And there needs to be continued conversation and clarity. Actually, looking at the cases, I think it's really important to look at incident by incident and learn from each one and figure out, how that supports understanding of where there are violations, then where there are crimes, and then, for example, the lack of clarity in the aftermath of the Kunduz report in Afghanistan, which we keep referring to because it was such a blatant and widely seen episode and had such a terrible cost in terms of death. In Physicians for Human Rights' view, there should have been a prosecution for criminal negligence, some form of accountability in a court. That never happened. There wasn't that kind of accountability, and yet, the devastation was extraordinary, and the one after another, there were repeated negligent aspects at every step. And so if there were clear guidelines and procedures and certain things would kick into place when a violation of that type occurred, we might have a better accountability.
And I think that's important because, my experience from dealing with nations, including our country, when healthcare has been attacked in various places around the world, is that there's this blurring of the lines, so that it's, we invoke words like terrorism, or enemies are hiding out, in these, they're not real hospitals, or they're used to, our enemies are seeking safe haven in these hospitals, and therefore, it's justified. These aren't hospitals like we all think of hospitals. And, and that's a very, very dangerous trend because it basically is kind of chipping away at any protections for healthcare. And how do you deal with that in this current climate where, when the rhetoric is so hot and, we invoke words like terrorism regularly, whether they're deserved or not. How do we have this discussion here so, the people who are saying, you want these guidelines, but, the bottom line is that, our adversaries are exploiting these protections.
Oh, you want to go first? That is such an important question. I think there are two responses. Number one, the Geneva Conventions anticipate the possibility of misuse of health facilities, of ambulances. And there's a whole analysis of how you address that problem as a matter of law, that they may be subject to attack, but you have to both give warning but also minimize harm to civilians, so that even if it's misused, the rules don't permit you just to attack it wantonly. But more importantly, I think we need to take on the rhetoric of counterterrorism head on, and that it cannot be an excuse, as you indicated, Congressman, to do anything. And it's such an undermining of the values that we've had of humanity, of impartiality, to basically make a blanket exception for counterterrorism that's actually quite pointless. There's no evidence that it actually makes anybody safer to attack a hospital or arrest a doctor for providing health care. So I think we have to take it on, and that's why I think legislation is needed to fix this problem. I think it's easily fixed. There is a global consensus on this,
right?
And the U.S. unfortunately has not joined that global consensus. That this is not. We must preserve the values and not allow counterterrorism law, no matter what the rhetoric is, to undermine the fundamental protections of the Geneva Conventions.
Mm-hmm. Anyone else wants to comment? Yeah, Ms.
I would just add that we need to keep bringing it back to the civilians, and that these laws are pursuing a security objective, and we're not opining on whether that is a good objective or not, but that at the end of the day, the target of these laws, of these measures, of this rhetoric are not the civilians. And so if the effect is that we as humanitarians, or not just us humanitarians, but anyone who is trying to provide medical help is not able to do so, then they're counterintuitive. They're not fulfilling their role. So I think we have to push back on a narrative that questions the relevance of the rules and reaffirm that they are fit for purpose. And then begin to speak about the specifics of the incidents that we're observing and be able to make a distinction between what is legitimate security interest from what is the needs of civilians all over conflict zones in the world. So, yes, I think I'll leave it at that.
Anyway, Bagwell?
So I would just add to that IHL is a body of law that is designed to remain in place in a nation's darkest days when they're in war. Looking back at our own history, when I mentioned earlier, in 1862, when we started drafting the rules that our Union forces would follow, we didn't know how the Civil War was going to come out. It was very much in doubt. And yet we believed as a nation that even in our darkest days, we needed to stand by who we were and uphold the law. Since that time, there's always been the debate. Perhaps in healthcare of the enemy, there's no better argument that military necessity would say, let your enemy die. Why would they get healthcare? Because you're removing them from the battle, and they won't, if they get treatment, they may return. But every time that question's been asked, certainly in the U.S. since the 1800s, humanity has always won. And so I believe it should continue to win today. I do think, and part of the question that makes things somewhat difficult is there is always the fog of war, and decisions certainly by U.S. forces that I've seen often are made with imperfect information, with fatigue, and with lives in the balance of the decision. And I do think that as we look at accountability mechanisms, it's important that we look at it with that in mind. And was this a deliberate attack, or was it attacks that could be prevented with better training, better equipment, better techniques? And reserve our criminal approach to those of deliberate criminal acts versus the problems with the others. Thank you.
Bruce Shurkin?
I would just add that when we look at the kinds of conflicts we're seeing today where these violations are the most egregious, including Syria, which I have mentioned repeatedly, Russia and Syria are defending. They're doing two things. They're denying that the attacks are occurring, but they're also clearly in their strategy and even some of the public rhetoric saying it's legitimate to bomb all these facilities because those people are terrorists and they're our enemies and they have done bad things, so they deserve to be killed. Because as we know, these wars are wars on civilians. They are intentionally targeting civilians, destroying communities, taking over land, et cetera, forcing people into flight, doing ethnic cleansing, et cetera. And so in preserving these humanitarian norms, the U.S. and other governments must educate people and our own militaries about exactly these norms, that even the enemy, even a alleged terrorist or a real terrorist deserve medical care. That's what these principles, these humanitarian norms require. And so we don't want to fall into the trap of doing or saying the same things as those perpetrators like Russia and Syria, who are deliberately bombing hundreds and hundreds of hospitals and killing patients, doctors, nurses, lab technicians, et cetera.
And I guess another way to say that gets to the same place ultimately. So we clearly have principles and values that we want to uphold that are codified in international law. And of course, Randall talked about how the Libra Code was the genesis of some of that. But more practically, sometimes it's hard to have internal consensus that this is something that really we need to focus on. And I think of the general effort that ICRC mentioned about the military's current effort to develop new military policy on civilian casualties, that has been a rocky road. And partially it's been a rocky road because there have been parts within the military that have said, civilian casualties, of course they're bad, but, they usually happen because human shields or it's either civilian casualties or military casualties. And so one of the things that I've been able to do over the past 10 years is get data and say, you know what, we over the last 200 incidents, there was not a human shield incident there, right? So that's not really true. Or looking at civilian casualty rates and friendly casualty rates and finding actually you can lower civilian casualties and lower friendly casualties. They're not mutually exclusive. So I do think having more information and being able to confront some of these arguments also strengthens our internal positioning.
I just have one more quick question, and then I'm going to turn it over to my co-chair, Chris Smith. I have to go to a Rules Committee meeting, unfortunately. But I talked about the incident in Syria that Russia, bears some responsibility for. Did we admonish Russia? Did we do anything in response? Did we say anything? I don't recall any kind of a U.S. response to that. Sirkin?
Well, I testified at the Security Council on July 30th and faced the Russian ambassador and confronted him with the same data that I presented here. The U.S. was there. The U.S. did speak forcefully against these attacks. Our previous UN ambassadors have repeatedly condemned these attacks at the Security Council. And of course, and the United States did go with many other members of the Security Council, the majority, to right away to meet with the Secretary General of the UN and request an investigation into these most blatant attacks. So yes, the U.S. has spoken out. I think it could do more along the lines of my testimony in supporting serious accountability measures, strengthening the Office of Global Justice at the State Department, as well as supporting these prosecutions that are slowly growing. From our experience over decades, even though justice takes many years, we believe it will eventually occur, even for Syria, even holding those Russian leaders accountable for these egregious attacks. But we have to, in the United States must also look to its own house as well.
Well, one of the things that Congressman Smith and I we have a shared frustration over the years when it comes to human rights is that oftentimes we've been very good about talking the talk but not walking the walk, and that, if the response to some of these things is just, protests in the UN, press statements, condemnations by somebody at the State Department, and that's it, then, that's not working. And so, Mr. Rubenstein, you mentioned if we were working on legislation, well, I'll be happy to help. Well, we are working on legislation, and we will work with all of you to get your input, because I think this is a serious issue, and it demands a serious response other than, and this is a good hearing to get everything on the record, but we need more than a hearing, right? So with that, I'm happy to turn it over to my co-chair, Congressman Chris Smith from New Jersey.
Thank you very much, co-chair and friend. As chairman of the Rules Committee, you're in committee every day.
Why did I want that job?
Thank you very much, I say to my good friend. Just a couple of things. Without objection, my opening statement will be made a part of the record. I was just in a markup in the Foreign Affairs Committee on about 18 bills, so that's precluded me coming and hearing your testimonies. Thankfully, we have copies, and I have read some, and I will read it more carefully probably at the end of the week. But I do want to say how grateful I am for the testimonies you've provided. One of the bills we just passed is a bill that I introduced. It's the Senate version, but it's identical. Although we made some changes in markup on the Uyghur human rights policy. I have 118 co-sponsors on my bill, including Speaker Pelosi, and we've tried desperately to get that legislation passed. We know that human rights abuse, which you're all very well aware of, and the concentration camps that are being filled to overflowing with Muslims who happen to be Uyghurs. We had one woman who came and testified at one of our hearings last year, and I was co-chair of the China Commission at the time. Now I'm ranking member, working along with Jim McGovern. But she said she prayed to Allah that she would die. I mean, so I'm glad that bill just passed, and it will be on the floor within days. Thank you for what you're doing on behalf of protecting healthcare and healthcare workers. I know that there's so many places where healthcare workers are put at risk of death and injury, and you have spoken out eloquently, I know, for years on their behalf. I know this, the ICRC talks about the South Sudan. In July 2016, when the terrain compound was hit, I jumped in a plane and met with Salva Kiir a few weeks later and argued with him. And before I left, I didn't know this until 3 days before I got on the plane, I had a healthcare worker from my district that was in the compound who was almost raped. She was one of the lucky ones who, it was stopped. There were 2 soldiers, and they were part of Salva Kiir's, the president of South Sudan's elite guard, who were very, very close to raping her. She resisted, and they shot off an AK-47 and said, that's for you next. And then, thankfully, somebody broke into the door and stopped it. So healthcare workers everywhere in war situations, in areas where human rights are not respected, or continue to be a problem. If you could, elaborate on the no weapons policy in South Sudan, I thought that was I'm glad you underscored that. If you also would perhaps speak to the Ebola crisis. We had briefings by Secretary Azar last week. Mark Green continually brings us up to date. I've been to Goma, but not recently, and we know how precarious that whole area is. But to think that so many healthcare workers are being put at risk as they try, at risk to themselves, notwithstanding the ability to get a vaccine that reduces the risk of getting Ebola, there's still, people are stepping up, in both indigenous DR Congolese and others from outside, to protect and to provide these services. Any insights you might have on how well that is going? Secretary Azar said that in talking to the president, the new president, and in talking to his health ministry, that they get it and they're trying to take full ownership over it. Of course, WHO and USAID is the prime provider of funding for this entire effort. But again, maybe speak to crises like the most recent one in the DR Congo and Ebola, how you think the healthcare workers are being treated. Do you see that we've turned a corner on that? My sense is that we may have, but not yet. But if you could speak to that as well. Again, I didn't hear your testimonies, so I wish I would have raised more questions based on what you have commented on, but the hearing kept me out.
Congressman, hello, thank you for holding this hearing. So you were referring initially to the no weapons policy in South Sudan. So just very briefly to say that this is just one of many examples of local strategies that we've developed around with specific communities and with the ministries. And it has been one of our success stories. Again, less in the realm of trying to prevent direct attacks against healthcare, but rather in just acknowledging that there are some ways in which the health facilities are run that could be improved and that build trust with the communities. And one of them was to make sure that there would be no weapons held there. What we find, unfortunately, in many communities is people adopting very negative and destructive coping mechanisms, not going to get the help they need because they no longer trust that hospitals are a safe place to be. So anything that we can do to make those places safe is very important. You spoke to Ebola. I think that what I would offer to you on that specific case is that all of the lessons that we learned as humanitarians from the previous outbreak were they were learned definitely, but they were definitely challenged and are challenged in the DRC because we found ourselves in a situation of armed conflict. So all of the trust problems that there were and there will be in a situation like that are just multiplied and exacerbated by the fact that you're dealing with communities that are being denied all of their basic services and needs initially. So when you add this in and the immense response that came in which was focused, of course, on responding to this outbreak. But for the communities that were receiving this outside help, there was really a lot of questions that emerged along the way about the motivations for these presents. So again, I think compounding the trust issue. You asked whether we've turned a corner. I think one of the remarkable developments is that this has not crossed borders. I think there was a real concern that the outbreak would, and how can we explain that it hasn't? I guess we can, because there's been some robust investment in neighboring countries to prevent that from happening through education, and I think certainly your efforts have helped in that regard. But that, I think, is one of the saving graces of the current crises. I cannot speak to the fact of whether, how close we are to resolving this issue. But from what I hear from my colleagues on the ground, it continues to be a daily struggle to contain this epidemic.
And there are therapeutics now that are working, and that's one of the greatest breakthroughs. So, and Dr. Fauci has done remarkable work on that in making sure, working with Merck and others, that is available. And then, of course, the vaccine has certainly been helpful too. But the healthcare workers themselves, through a whole lot of disinformation, were put at grave risk as they went out some people were even calling it Ebola Incorporated, that somehow, the Westerners were coming in. It was all disinformation by a very small group of people, but it had an impact. And I'm hoping that's abated.
Congressman, if I may add a few words. First of all, I'd like to thank you for holding the hearing and your leadership on human rights going back 25 years, the genocides in the 1990s, and your commitment to the African region where people suffer so much. So I wanted to thank you for your leadership. In the Ebola outbreak, there have been many armed groups, different kinds of armed groups engaged in these attacks, and as you know, there have been very many. And the initial response was unfortunate because it was in some ways a militarized response. It was a coercive response on the communities who themselves were suffering. And that undermined the same kind of trust that we just heard about from my colleague, and in some ways exacerbated the problem. Without building trust, as you know, in communities, you'll never make any progress. And these communities have suffered from thousands of people being killed in these wars, and they don't have a lot of trust in their own military. The peacekeepers are trying to do a better job, but they're not fully trusted either. They're seen as not providing the protection of them in the past. They don't trust their government. They don't trust their Ministry of Health because their health needs have been ignored. So we have to think of different kinds of strategies rather than a militarized one in making sure health workers are protected. There's room for peacekeepers to play a role in that protection, but I think we need to take a sophisticated approach, and it is now starting to happen there. There's a much more nuanced view by the WHO and all the other actors, but in a way it got started on the wrong foot and tended to make the situation worse.
If I could speak to the issue of mental health, Save the Children suggests that 3/4 of all child casualties were caused by explosive weapons, and to those who survive, the trauma, the pain is excruciating. I got elected in 1981, 26 years ultimately as chairman of the House Committee on Veterans Affairs. And one of my biggest takeaways was the PTSD that comes from an injury, as well as being involved or in proximity to a conflict. And for children, I mean, it only has to be compounded by their inability to process what's going on and their helplessness. And I'm wondering, how you would assess the approach, the availability of good interventions to help children with PTSD and other mental health problems attributable to war and conflict. And if you could, last year, President Trump signed my bill that reauthorized for 5 years the PEPFAR program, which is, I think, is one of the greatest legacies of George W. Bush ever. I mean, we're spending about $6 billion per year. This was a $30 billion reauthorization. It was bipartisan. Barbara Lee was my chief co-sponsor. But one of the takeaways of all of that was the not just HIV, AIDS prevention and ARVs and all the other important interventions, but the availability of safe blood, particularly in warlike situations. And I chaired hearings on safe blood. I know USAID does a good job on safe blood, but it's very often, I've been in hospitals throughout Africa where I always ask to see, what's your availability of blood? Do you have it? Who are your donors? And I'm wondering, especially in these conflict areas, is there an availability of safe blood for transfusion, which literally saves lives? And if you could speak to the PTSD issue as well of children. Everybody's looking at Rand.
Thank you again, Co-Chairman Smith, for convening this hearing. It's such an important topic, overarching all of this issue of protecting health in conflict. And regarding the trauma, what we've been focusing on largely today has been the ways in which access to health care is denied or prevented or obstructed, whether it's from the bombing of hospitals from the air, or whether it's by stopping transport at checkpoints, as we've heard from Randall Bagwell, and the ways in which aid needs to get through. That includes supplies, drugs, blood. All of this is compromised when healthcare comes under attack. And in terms of the trauma issue, when hospitals become places that people are afraid to go to, whether it's because of the type of mistrust, or clinics, in the case of Eastern Congo, for example, mistrust of the delivery of the healthcare system, or because they've had an experience of violence literally inside the health facility, then the trauma is compounded. And places that people, we see this in Syria, we see this in Yemen, but we also have seen this in Eastern DRC. I'm sure to some extent this must be the case in the conflict in South Sudan, where these places that should be sanctuaries are no longer properly protected. And that, no doubt, prevents whatever minimal psychological or mental health care is possible. But also the exacerbation of the trauma of war that's already there, when the places that one is supposed to have hope in and feel are safe, or the doctor or nurse who's supposed to be protected is not. And in our experience at Physicians for Human Rights, we've seen how traumatized whole families can be, populations. When a woman needs emergency obstetric care and cannot get to the hospital because the ambulance is bombed, or because there are people shooting at her as she tries to enter the hospital, or she gets in the hospital and she's in the middle of a C-section and there are bombs falling on the hospital. So, of course, all of this creates trauma. And I'm sure those in the humanitarian aid field and ICRC are more engaged than we are in actually trying to deliver and assure mental health services. But as we mostly know, this is the last thing on the list, usually, for medical care is psychological support. And it's a big problem. It needs to be increased. And we have now generations in the conflicts in Syria, Yemen, and elsewhere, Sudan, that have only known war. So, and children are not getting educated, and they're seeing their parents killed.
Before you go on, and maybe you could add to your answer this. When I became aware of that there were something on the order of 70,000 Christians, including a number of Yazidis, that made their way in and around Erbil, escaping ISIS, I chaired 10 hearings on it, tried to get the administration to administratively provide more help to them. I ended up writing a law. It was signed by Trump last year, and it provided aid, as well as on the part 2 of it, or Title 2, was all about ensuring that information to hold the perpetrators accountable was faithfully captured if there ever is a prosecution or a series of prosecutions. One of the biggest takeaways when I went to Erbil, and I went to an IDP camp there were like 6,000 to 7,000 people there, mostly women and children. I spent the whole day there. I was with the bishop and a few others, and I kept asking, about the kids and about their mental state. And one thing that I learned from that, and I've seen it elsewhere as well, but I heard it there again, was that their faith helped them rise above it. They're still hurting, traumatized, but they, almost like the 10 steps for Alcoholics Anonymous, very often it is that appeal to a higher being that helps one really get a better perspective or a new perspective, and helps with dealing with the victimization. And I'm wondering if you find in your work that inclusion of faith-based entities, clergy of all kinds, Muslim, Christians, Jewish, whatever, is helpful in the healing process. Because I saw it. I met with whole families, again, the whole day, just one meeting after another, all informal, sitting around table, talking to families. I picked where I wanted to go and talk to folks, and they pretty much had the same idea that their faith had really, in God, had helped them to have a perspective that gave them a coping mechanism to, again, they're not cured, they still have nightmares, but do you find that in your work?
Well, I myself have been in Erbil and Dahuk 5 times in the last 2 years and have spent time with the Yazidi community. And in my experience, and I'll just speak personally, not from our organization, that community leaders, whether they're faith-based or other respected leaders and trusted leaders of communities, are able to gather people together in the face of these atrocities. What I would be concerned about right now, and what I've heard from Yazidi and other minorities who've been persecuted in northern Iraq, is that, as we know, given what's happened recently in northeastern Syria, Yazidis themselves have come under vicious attack in the last few weeks as Turkey has moved in. And there are new IDPs arriving now in Dahuk and in Erbil with huge trauma. Children have been killed. We've had reports, actually, of health facilities and health transport coming under fire. We're still trying to investigate that and confirm it. This is of these very populations that you're describing. No doubt, healers, community leaders, people of faith who support those populations bring hope. We work very closely in the Eastern Congo with our dear friend, Dr. Denis Mukwege, who won last year's Nobel Peace Prize. I've been at his hospital. There's very powerful prayer there every morning. It certainly brings hope, but it doesn't bring medical care always, and protect it necessarily, and that's what, policy that's beyond any particular group or entity or ethnicity or religion needs to bring.
If I may, definitely we see the importance of religion and religious leaders in every conflict in which we work. One of the places where we work most as an organization is in prisons. And anyone who's been in a prison knows the importance of faith. You mentioned before mental health, and I just wanted to connect the two because I think you were referring to the resilience of the people you met and what they were essentially holding on to go through the tremendous suffering that has been inflicted on them. I think mental health, there's been a huge progress in, as Susanna said, acknowledging the importance of mental health as health. But more needs to be done because it does remain a taboo. I mean, it remains a taboo for humanitarians, frankly. We don't do very much for ourselves when it comes to mental health and what we experience on the battlefield. I think we're doing better, but it's relatively new that we acknowledge trauma. You've talked about PTSD in the military. I mean, it's also an issue that we can relate to. So I think that the mental health piece is the so-called invisible scars that last and that ultimately will impede any efforts to reconciliation as well, need to be documented and talked about. And so it's really heartening to hear you talk about it. And I think that in your engagement with religious leaders of all faith, I think that's also a place where there may be space for pushing these leaders to acknowledge this as an issue that needs to be addressed, and that's not necessarily just addressed through prayer, but actually needs other kind of response. A word about stigma. I think that we were just talking about the Middle East. There are populations that are stigmatized for being perceived as affiliated with Islamic State, that we're seeing these communities in Iraq in particular being finding it increasingly difficult to find their way forward. I think that the question of stigma is a question that attaches to most conflicts, and it is one that we need to be able to speak about more openly, and certainly connecting it with the mental health needs of those people who are combating stigma and trying to reintegrate a society post-war. Thank you.
If I may add just a couple of brief points on the question of children and trauma in war. Everywhere it's been studied, in Syria, in Gaza, everywhere, the trauma is profound among children. And not only that, it's intergenerational. It's like the children of these children are affected by this war trauma before they were born. And we have made some progress, but there simply aren't enough resources, as you know, to address it. There's another element of trauma we haven't mentioned. My colleagues and I at Johns Hopkins did a study of interviewed about 100 Syrian doctors and other health professionals on a different topic. But in the interviews, their trauma came to the surface. We talk about health workers as resilient, and they are, but after being in hospitals where they're bombed for 8 years, they are traumatized, profoundly traumatized. And the donor community has not provided resources. They'll provide resources for scalpels and for medical supplies and for salaries, but they do not provide any psychosocial funding for the traumatized health workers. And I think that is something that needs to be addressed.
So, yes, great point. And you mentioned the trauma from explosive weapons. So I just want to point out there's been a lot of discussion about the treatment afterwards, but there's also work we can do beforehand to avoid the use of explosive weapons that is disruptive to human lives. So I just want to mention that there is an international initiative and a drive towards a joint declaration on the use of explosive weapons. And I think right now the U.S. has been involved, but they really haven't been a leader, and I think they could be. The U.S. has learned a lot of hard lessons over the last 20 years in terms of our military operations, and we've learned a lot on what to do and what not to do. And not to say that the U.S. is perfect by any means, but I think we have some lessons that can help guide that discussion. Right now, we really haven't been a
If you
leader
could just,
in that.
where is that occurring at the UN?
So there are a series of discussions. I think there's going to be one in Austria, I believe Austria, at the end of November.
Under the auspices of?
So it is a joint declaration that there are a couple countries that are championing this, Ireland, Austria, and I think New Zealand as well. So I mean, I'd be happy to talk to you offline about how those look. But there's been a series of discussions in various forums over the last few years, and it hasn't really gone anywhere, but it seems like this is actually progressing, and I think the U.S. could have a more constructive and wholesome contribution.
If I could ask you, is there anything you think we could be doing in U.S. law? I mean, we've provide Magnitsky sanctions on individuals. That's a very useful tool for people who commit egregious human rights abuse. But is there something missing in our statutes that you think we could or should add in this area, particularly to hold perpetrators to account when they target ambulances and the like?
I'm not sure that the laws do not exist. It's really acting on laws that already exist and assuring accountability. So in my testimony, you'll see that I gave some ideas about how the U.S. could support prosecutions for violations where the Security Council, in the case of the most egregious ones, that would rise to the level of the International Criminal Court statute, where the U.S. could support, through universal jurisdiction cases, prosecutions. And that would be through strengthening efforts at the State Department's Office of Criminal Justice or Global Justice, and also really following our own laws and assuring that both the U.S. military as well as allies that are using U.S. weapons or U.S. military aid are adhering. I'm sure there are some gaps in law. I'm not an expert on that, but I think it's something worth pursuing and considering as you move towards some possible legislation that would encompass a lot of the issues that we've been discussing today. Because I think among all of us and others who aren't in the room perhaps, who've thought about this a lot, there are improvements that could be made in both law and practice.
Does the ICC pay enough attention to this and its prosecutors, including the lead head prosecutor?
Well, unfortunately, the docket of the ICC does not have many of the cases that we've been most concerned about recently to deal with. And what Physicians for Human Rights has been very interested in is assuring, and this is in UN Resolution 2286 of 2016 that the U.S. supported, that there be accountability measures in the face of egregious violations of the laws protecting health and delivery of health care in conflict. And we have not seen cases of these kinds of crimes coming before hardly any courts, whether they're regional bodies or the International Court. These cases are hard to prove because we need evidence. And we've all noted, or a number of us in our testimonies, the very powerful evidence that the New York Times Visual Investigation Team provided of Russian targeting of hospitals in northwest Syria. That kind of evidence is critical. In my written testimony, I also mention that the State Department could indeed re-up support for non-governmental organizations that are gathering evidence and documentation for such courts. We supported Syria to be referred to the International Criminal Court. Russia and China vetoed it. That's not going to happen in the near future. But there are other ways to prosecute. And the U.S. needs to do as much as possible to provide its own evidence to any effort that's going on, including the IIIM established by the UN.
But, we did have a window of opportunity several years back, and I actually wrote an op-ed for the Washington Post, and then had a series of hearings and then a resolution that passed on the House floor asking for a hybrid court. Now, the ICC, fine, if they can do it, break out the champagne, and we'd be happy to see it happen. But they have not shown the ability, in my opinion, of 2 convictions, maybe it's 3 by now. But the hybrid courts in former Yugoslavia, which we had a lot of lessons learned from that one, Rwanda, and especially the Court of Sierra Leone, they focused on, particularly David Crane, who was the lead prosecutor. He sat right where you sat and backed the idea of pushing a hybrid court for Syria and Iraq. We still haven't gotten it. And I know, yes, Russia could veto it, but they didn't veto the one for Yugoslavia because it was made very clear that Bosnians and Croats who commit war crimes and crimes against humanity would be equally held accountable, not just guys like Milosevic. I still hold some hope, but I think we kind of lost that window to get that done in the early days. Now Russia is fully involved and complicit in these war crimes themselves, so it might be a lot harder. But
absolutely, hybrid courts can be a very important solution, and we've seen that.
And we did want to include the targeting of health ambulances, as you put it before, as part of that effort. But
well, these are war crimes that rise to the level of prosecution in these cases. It's as much the building of cases that's important, and I think the U.S. right now could do more than it's currently doing, very likely, to support
Could
the
you
investigations
elaborate on that
that
either
are
now
already
or,
going on.
because again, our law that Trump signed, it was my bill, and I actually was the chief co-sponsor, and we worked hand in glove to get that bill passed. Part 2, Title 2, is all about, trying to save evidence, because evidence does evaporate like to do, and so that people's memories don't fade, get it down on paper, and there are some very good NGOs, as you know, you guys too, who are collecting this. Are we not providing enough? Because that was explicitly authorized in the act.
There could always be a lot more, but I also think that, and this is in my testimony, and be delighted to discuss it further, the sharing of U.S. non-top secret intelligence, as the U.S. did for the Yugoslavia Tribunal, as you know, could probably be improved and increased, as right now the only game in town is these national prosecutions, as to Syria, for example. And of course, with what is likely to be the ultimate victory of the regime of Assad with Russian support, and as we're seeing now playing out, it's very unlikely that even a hybrid court could be established anytime soon. And that's why, in my testimony, I speak largely to these national prosecutions. And there are many people in Europe who could be prosecuted. I would also add, and this goes back to the Yazidi question and the children, that we've been working on the justice situation in Iraq, and there are, as you probably know, many thousands of detainees in Iraqi detention who are charged with being members of ISIS, almost always tortured and executed. Among those detainees, where the system is not adhering to any kind of standard under international law, are possibly young children who were taken, including Yazidis, and made to fight for ISIS. And when we're talking about humanitarian law and the understanding of the rights of all in war, we have to understand that we can't just sort of paint all of these people, and often children even, with one brush and assume that it's okay for them to languish in those kinds of detention centers. So it is a way for the U.S. could have much more influence over Iraq in its treatment of detainees right now, and understand that it's a very complex range of people, including very young ones, in those centers.
So,
Yeah.
okay, yeah. So great points about accountability. The other thing that helps accountability is when we create a sharper contrast between what we do and what they do. So I do think that you're talking about measures that could be in law, that there are things that we can do to do better, to be more deliberate, both in what we do, but also the way we work with our partners and having more effective influence. Of course, Iraq, Yemen, those are areas of concern, and if we can better deal with those, and I think it makes it easier to draw a contrast with Russia and others that are doing these things deliberately.
I just asked earlier about the law, what could be done. I saw firsthand in Iraq how the effects of the Leahy law on human rights had a real impact as we worked to ensure our partners were in the military were upholding human rights, or gross human rights violations were being investigated. A law similar to that, where we looked at how our partners are treating healthcare in danger, how we react to that, something that is linked to armed cells. Also encouraging our own training and doctrine review within our own military to ensure that we go deeper than where we go right now with our own training. I think something along that measure, that particular law had a great impact. And I think a law in this area could also have a great impact.
Which is not accountability for others, but getting our own house in order. Like many other countries, our counterterrorism laws are very broad, and they encompass, the way they've been interpreted has been to encompass medical care as a form of material support of terrorism. And these laws are inconsistent both with the Geneva Convention's requirements of impartiality and humanity, that every human being, no matter what they've done or who they are, should get medical care, and also medical ethics, where physicians and nurses are obligated to treat everyone, irrespective of who they are, because that is part of their medical duty. And we, I think, are united on this panel in believing that it's very important for the U.S. to set an example by changing those laws to exclude medical services, humanitarian services, as a form of material support of terrorism. We don't think those laws make us any safer. They don't stop terrorism, but they impede medical care and have an incredible chilling effect on humanitarian
I can ask,
action.
so if a doctor were to treat a terrorist?
That's a
they would-
crime.
That's a crime.
That's a
And they
crime
would
under
be-
U.S. law. The law could be interpreted differently. The law says medicine is excluded from this prohibition. But the Justice Department and in public speeches, the government has taken the position that although medicine is excluded, the people who provide the medicine are not. So medical care is considered material support, and that's how prosecutions have gone forward. It also affects asylum cases, unless there's a waiver. If you're fleeing a country, I talked about this in my testimony, that a Chechen physician who treated both sides in the war 20 years ago was given asylum in this country because we believe that he was doing his duty and he should be given refuge. But today, he might be denied unless he got a waiver.
Now, is the waiver focused on whether or not he or she carried a gun and did other things to advance terrorism, or just operations and the application of good medical care?
It's a completely discretionary kind of waiver. I don't believe there are those kinds of criteria used, and it varies tremendously.
Thank you for that. I'll look into that. I thank you for your testimony, your generosity with your time this morning, and above all, for your expertise and your leadership. Hearing's adjourned.